Can you hear me?
Good morning, sir. Yes, sir.
Today we'll talk about this viral hepatitis, and as we have got two classes, but I think I can finish it in one class. Actually, this viral hepatitis generally is a collection of the diseases and usually caused by some viral agents and. But we generally think that whenever we talk about viral hepatitis, it's due to hepatitis A, B, C, D, or E. But actually, there are other viruses also which can cause viral hepatitis, like cytomegalo or Epstein-Barr or herpes simplex, yellow fever virus. Almost all viruses can cause viral hepatitis, but as these hepatotropic viruses like hepatitis A, B, C, D, E are more important for us. So we'll talk about these hepatitis A to E in this class. And generally, we can find that viral hepatitis can be because of acute or chronic hepatitis or acute hepatitis. And generally, if you look at it, then almost all human hepatitis viruses are RNA virus, except for hepatitis B virus, which is a DNA virus. And we usually keep this in a collection like in a one class like hepatitis because they have got more or less similar features and they are more hepatotropic. That means though these are systemic infection, hepatitis viruses are systemic infection, but they are very much attracted to liver and thus causes the inflammation of liver. So these are called hepatotrophic viruses or hepatitis viruses. This is a systemic infection, but affects liver predominantly that I just told you about. So these have got similar clinical and pathological features, but they can present in a varied ranges, like the patient may be asymptomatic, or may have subclinical persistent infection, or may have a rapidly progressing chronic liver disease leading to fulminant or fetal acute infection. Patient may land up with cirrhosis without knowing that patient had hepatitis previously, or may have even hepatocellular carcinoma, especially in hepatitis C and B. These cirrhosis and hepatocellular carcinomas are more common. If you look at it in hepatitis or hepatotrophic viruses that we have A, B, C, D, E, generally A and E are the viruses which causes acute infection only. They don't have chronic infections. B and C have chronic infections as well as acute infection. And hepatitis D is an incomplete virus. And this cannot alone cause any infection, but can cause infection along with hepatitis B. So this is an incomplete virus. Without B, this cannot cause infection. Hepatitis E are usually they spread through the orophycal route. E also is the same route. B, C, and D are usually because of the blood, saliva, or sexual vertical transmissions are possible with B and C, and D also. There are few vaccines that can prevent these hepatitis infections, especially hepatitis B and A have got vaccines, and they have got varied incubation periods, like the longest one with hepatitis C. They have got a longest incubation period. Then B, A, and E have a shorter or weeks long incubation period. So if you look at, I told you that every are the RNA viruses except for B, which is a DNA virus. Now, in short, hepatitis A virus is a heat, acid, and ether resistant RNA virus, and this can be inactivated by just boiling for 1 minute or formaldehyde or UV irradiation. Replication is limited to liver. They may be present in liver, bile, stool, or blood during late incubation period and acute pre-iterative phase of the illness. Um, though there is a persistent of virus in the liver, there will be viral setting in feces or viremia, and infectivity diminishes rapidly once the jaundice becomes apparent. And anti-HAV, which is the antibody against this hepatitis A virus, will be detected during illness, and this liver function test will in the where the aminotransferase will be elevated, and patient who has got anti-HAV are immune for reinfection. So once you get hepatitis A virus infection, then you are immune for lifelong, like just like getting a vaccine against that. In the hepatitis B virus, this is a DNA virus, and they have got few viral proteins and particles that are very important, of which hepatitis SBS, AZ, CAG, EAG, and DNA polymerase. SAG is a surface antigen, and this is we call the antibody against this antigen is anti-SBS, which is a protective antibody. Usually, once you are vaccinated, you are vaccinated with this antibody, so you'll not get hepatitis B infection. C is in the core antigen, and it is in the surface of the nucleocapsid core. And another important one is EAG, and EAG is the this is the nucleocapsid protein, and persistent the persistence of SBEAG would signify that the virus is replicating. So whenever you have got a patient who has got E antigen, then we say that the virus is active and it's replicating, and it has got infectivity. So persistence of hepatitis EAG for more than 3 months, then we call that one as a chronic infection. DNA polymerase is within the nucleocapsid core. And what is also important is that a patient who has been infected with hepatitis B virus can also have anti-SBS, but and the person who has been vaccinated will also have this anti-SBS. So to differentiate that, we can look at the E or C antigens. If C antigen is present, then we say that the patient has got this anti-SBS due to hepatitis B infection. But in those patients who are vaccinated, you will have only anti-SBS, but you won't have any SBCAG or anti-SBC. So to differentiate this core antigen is important. Now, if you look at the natural progression of the disease, if you get infected over here, then by few weeks or by few days of incubation, there will be predermal symptoms that are very much similar to that of any kind of viral infection like fever, malaise, and you may have arthralgia, you may have distaste or decrease in appetite. Those very viral prodromal symptoms will be present, which you may not be able to differentiate from other viral illnesses. But once you have a jaundice, appearance of jaundice, then the fever will go down, and there will be only a brief period where you will have fever and jaundice together. So as the patient develops jaundice, the fever subsides, and that is very peculiar of hepatitis infection. And once you are infected, then you will have increase in SBSAG, and you'll have SBEAG also, and this will indicate that the patient is having active infection and virus is replicating. There will be increase in the liver enzymes. The patient will have jaundice, and after some time, as the infection subsides, then the SBSAG will gradually go down. There will be a window period to reagain, and patient will develop the antibody SBS, which will be present for lifelong. And there are two actually kinds of anti-SBC also. So the first one will be a IgM, and then we'll have a anti-IgG, anti-SBC. This will not be present if the patient has been vaccinated. You'll have only anti-SBS will be present. And once the patient's infection gradually decreases, this SBEAG will disappear, and anti-SBE will be present. SBEAG will be absent from the blood. So it takes some time for jaundice to improve, and though patient may be recovering from the infection, there may be jaundice for sometime like 2 to 4 weeks after the recovery of the patient. C is RNA virus, and these have got many subtypes, 6 genotypes and subtypes. There are many subtypes also, and hepatitis D, as I said, is a defective RNA virus, and it just is possible with co-infection or superinfection with the hepatitis B virus. Hepatitis E virus is also internally transmitted, which is common in Asian countries, South America and Central America, in African countries. And they will develop anti-HEV, which can be of M and G type, IgG-M and IgG type. And they may shed this virus in the stool, bile, and hepatocytes. Actually, if you look at how these viruses causes the infection, it's quite interesting though, that viruses, this is a systemic infection, and you'll have a viremia also, and can affect any organ, but these have a particular attraction to the liver cells, hepatocytes, and they go inside the cell, but they are not actually directly cytopathic. They don't destroy cells themselves. But what happens is that once the virus goes inside the cell, then our immune system will destroy the hepatocytes. So you'll have an injury in the liver, causing increase in aminotransferases and increase in jaundice. So the clinical manifestations and outcome is usually determined by the immunological response of the host. There are many extrahepatic manifestations like serum sickness, like syndrome, glomerulonephritis, nephrotic syndrome. Especially patient may have messenger proliferative glomerulonephritis, polyarteritis nodosa, and essential mixed cryoglobulinemia. These are usually commoner with hepatitis B and hepatitis C viruses, and even a membranous nephropathy may be present, especially with hepatitis B, and messenger proliferative glomerulonephritis with hepatitis C. So if you look at it as the pathology, then there will be an infiltration of mononuclear cells, and hyperplasia of Kupffer cells. There may be some cholestasis. This cholestasis is especially commoner with hepatitis E virus rather than other viruses. There will be a regeneration, Councilman body, and in hepatitis C, there will be a relative paucity of inflammation. In D, you will have a marked E, you will have a marked cholestasis, and there will be bridging hepatic necrosis. And if the patient has got fulminant hepatitis, then there may be massive hepatic necrosis, and there will be small shrunken liver in fulminant hepatitis. In the clinical symptoms, you'll have a prodromal symptoms like anorexia, nausea, vomiting, fatigue, headache, fever, photophobia, cough, coryza, arthralgia, myalgia, everything similar to that of any other viral infections. You'll have low-grade fever. I told you about fever, that once there is an appearance of jaundice, then the fever will disappear. There may be dark urine or called stool, clinical jaundice, mild weight loss, liver will be enlarged and tender, but if you have fulminant hepatic failure, then there may be shrunken liver as well. There may be splenomegaly with cervical adenopathy and spider angiomas in some of the patients. During the recovery phase, constitutional symptoms will disappear, and the liver enlargement and liver function test still will be deranged. The post-ectatic phase, that means the presence of jaundice may be there for 2 to 12 weeks, and there will be a complete recovery in the hepatitis A and E by 1 to 2 months, and B and C by 3 to 4 months after the onset of jaundice. But the B and C can have a chronic course, and they may convert into chronic hepatitis B and C infection. If you do a test, then a liver function test, prothrombin time, there may be neutropenia and lymphopenia. In serological test, as you go through, like there may be HBsAg positive, anti-HIV positive, or anti-HBC positive, anti-SCV positive. You can go for liver biopsy, and sometimes it may be confusing, and especially in hepatitis C virus, antibody to liver kidney microsome may also be present. Monitoring of blood sugar is very important because they are prone to have a hypoglycemia. These are the other differential diagnosis, like hepatitis due to other viruses or due to other pathogens like Toxoplasma, Candida, Leptospira, Brucella. That may be hepatitis may be because of drug-induced or alcohol hepatitis, cholecystitis, acute fatty liver, pregnancy, malignancy, metabolic disorders. Like these can be a differential diagnosis for our acute hepatitis or chronic hepatitis. In the complications, you may have relapsing hepatitis, cholestatic hepatitis, serum sickness-like syndrome, or fulminant hepatic failure. And sequelae in where chronic hepatitis is very common, and especially in B and C. In the rare complication, you can have pancreatitis, pneumonia, plastic anemia, HSP, or can have renal failure, AKI. They may remain as a carrier, especially in B, and patient may have cirrhosis and hepatocellular carcinoma, especially in hepatitis B and C. Actually, prognosis is very good, especially in hepatitis A and E, where they almost recover. In hepatitis B also, in acute hepatitis B, around 95% of the patient will have a complete recovery, but only around 5% will have chronic infection. But in the hepatitis C, it's just reverse. most of the patient will have go into chronic infection, and only some people will have complete resolution of hepatitis C. In hepatitis E, especially in India and Asians, there may be a little of more of case fatality, around 1 to 2%, and this may increase to 10 to 20% in pregnant women. So they may have a bad prognosis in pregnant women. And I didn't tell you about the treatment, because actually there is no treatment for hepatitis A or E. These are all only the symptomatic treatment, just avoiding hepatotoxic drugs, taking a lot of fluids, and taking a lot of glucose containing food. These are the only symptomatic treatment you would go for, okay? Especially in A and E. Now in B, also you don't treat acute hepatitis B, but for the hepatitis C, you can treat it, which is same as that of chronic hepatitis. So I'll talk about that in the chronic hepatitis. In like acute hepatitis, chronic hepatitis are also because of a lot of other things like chronic hepatitis, viral hepatitis, drug-induced autoimmune, and metabolic like Wilson's or alcoholic liver disease. And so the differentials will be these things. And in the chronic viral hepatitis, it's only B and C that are important for us. Usually, while you classify the chronic hepatitis, it can be classified as an etiology, or through histological aptitude or grade, or degree of progression as stage. So previously, they used to classify it as a chronic persistent or lobular or active hepatitis. But nowadays, they are being now classified according to the grading, or there are some score systems like nodal CSAC system, which is similar to, I'll come to that one in a chart. And in the staging, there's like 0, 1, 2, 3, 4, where there is no fibrosis, mild fibrosis, moderate, and 4 is cirrhosis. This is the scoring system of the, which is called histologic activity index, HAI, and where you look at the periportal necrosis. This score system is usually based upon the biopsy findings, and we look at the periportal necrosis, whether there is interlobular necrosis, portal inflammation, fibrosis or not, and maximum score is 22. So by this, they have classified chronic hepatitis nowadays. If you look at the hepatitis B, if you have an infection at birth, then this acute infection at the birth, then there's a 90% chance that you have a chronic infection. But in patients who have got very good immunocompetency, and if the patient is a young adult, then there is only 1% that patient will go into chronicity. So most of the patients of acute hepatitis B usually recover, and there is only 1 to 5% chance that it will convert into chronic hepatitis. Then the grading of liver injury is variable, maybe asymptomatic or mild or severe, and they are more important to consider the degree of hepatitis B virus replication. So you have to look at the whether there is a presence of SBEAG or not in patients. So if you have a SBEAG positive for more than 3 months, then we call that one as a chronic hepatitis B infection. And there's more chances of risk of hepatocellular carcinoma and cirrhosis in these patients. And then, if you look at the clinical features, most of them would be asymptomatic but they may have fatigue or intermittent jaundice, malaise, or anorexia, but sometimes they may present with the features of cirrhosis also. There will be complications of cirrhosis and may have ascites, edema, varices, encephalopathy, coagulopathy, and hypersplenigism with splenomegaly. There may be extrahepatic complications like arthralgia, arthritis, leukocytoclastic vasculitis, or immune complex glomerulonephritis, and polyarteritis nodosa. These are the extrahepatic complications, and usually laboratory findings do not distinguish between the mild or severe hepatitis. Aminotransferase may be normal in these patients. Bilirubin may be normal in this patient, but they will have hypoalbuminemia, and prothrombin time may be high. And for the markers of chronic, there will be SAG would be positive, and SBEAG may be positive also in these patients. Treatment is more or less depends upon the viral replication. Generally, they are indicated for more replicative form of hepatitis B, and if the patient has got increased ALT, and if you have a patient has got hepatitis B DNA viral DNA, when you do liver biopsy and you find that it's a chronic hepatitis, then they start treatment for that. So if a patient has got acute hepatitis B infection, they consider to wait for 6 months prior to starting the antivirals. And if the patient has got persistent like this replicative hepatitis B, detectable SBAG or SBV DNA, increase in alkaline phosphatase, alanine transformase, and chronic hepatitis in liver biopsy, then they go for treatment. In treatment, they give interferon alpha, entecavir, tenofovir, or lamivudine. Usually, lamivudine this usually is now considered as second line because most of them are resistant to lamivudine. And interferon is usually given for 16 weeks, and there's a relapse after successful treatment is rare in these patients. And interferon, lamivudine, and some patients nowadays they're usually using this entecavir and tenofovir as well for the treatment of hepatitis B virus, chronic hepatitis B virus. And for the end-stage chronic hepatitis B, it's a liver transplantation. In chronic hepatitis C, it's the other way around. It follows the acute hepatitis C in 85 to 90%. And the cirrhosis is also high. It's 50% of the patient will have cirrhosis, but they tend to be very slow and insidious. Cirrhosis will be even after 10 years of acute hepatitis C infection. So it's slow and insidiously progressive. The progression is usually in the more in the older ages, longer duration of infection, and we have got genotype 1. And if the patient has got increased hepatic iron, then they progress. Progression is more in these patients. And liver histology is also a best prognostic for indicator whether the chronic hepatitis C will progress or not. If you have a patient with a compensated cirrhosis due to hepatitis C, then 10-year survival is 80%. Mortality occurs at the rate of 2 to 6%, decomposition at the 4 to 5% per year, and hepatocellular carcinoma at the rate of 1 to 3%. So actually, hepatitis C is more dangerous than hepatitis B, but we have got only vaccine for hepatitis B. We don't have vaccine for hepatitis C. So there is one, we usually see that the people of public health usually are more focusing on hepatitis B rather than hepatitis C. So actually, if you look at the scenario, hepatitis C is more dangerous than hepatitis B. Moreover, these are the usually clinical features. You'll have fatigue, jaundice, and may have features of cirrhosis. And you can have extrahepatic complications like mixed cryoglobulinemia, Sjogren's, lichen planus, or porphyria cutanea tarda. Aminotransferase levels with the presence of autoimmune LKM may be present, and you'll have histopathological features. Indication for the treatment is that whenever you have a detected HCV RNA or increase in ALT, here you don't wait for a patient to become chronic. Even you can treat the acute hepatitis C virus infection rather than unlike in the hepatitis B virus. Usually they go for combined therapy, and there's a monotherapy of interferon also, but combination therapy is interferon with ribavirin. They have got quite a high relapse rate with interferon, and nowadays with the combination therapy, more and more good response to the treatment are being observed with combination therapy like interferon, ribavirin, and patient have even nowadays have a very good drug for hepatitis B virus, which is NS5B polymerase inhibitor. It's called sofosbuvir, and this has got a very good recovery rate, and they are usually given for 6 months, and they have the successful cure rate is also high, and relapse rate is very low in this patient treated with these patients. Other are boceprevir, telaprevir, similprevir, and the one I have told you about is sofosbuvir. So for the prophylaxis, it's better to have a prophylaxis rather than an infection, and we have got a vaccine for hepatitis A, and nowadays even in Nepal also it's been included in extended hepatitis in the immunization schedule also, and in hepatitis B we have got standard the IgG with the which contains anti-SBS, and immunoglobulins, SBIG, and current recommendation is divided into a pre-exposure prophylaxis and post-exposure prophylaxis. In pre-exposure prophylaxis, you give just vaccines, and you give 3 doses, first dose, and second dose after 1 month, and last dose after 6 months, and usually given in deltoid, but if the patient is immunocompromised, then the vaccine schedule is a little bit different than this. We give 4 injections and doubling the dose also. So we give not 1 ml but 2 ml of vaccine on 0 day, 1 month, 2 month, and 6 months in immunocompromised patients. If you have in post-exposure prophylaxis, you'll have to give immunoglobulins, then led after then you start the vaccine after within of 12 hours of life, and if the patient has been like this may be more in commoner in patient who are born in a pregnant lady with hepatitis B infection, or who has got occupational hazard, like patient was like a person who is a healthcare worker. They may have exposure to the blood, which is contaminated with hepatitis B, where you also give immunoglobulin as soon as the exposure, and then you follow the course of hepatitis B, which should be taken within first week. There is no such for hepatitis C, because there are many genotypes and many subtypes, so we don't have a vaccine for hepatitis C. They haven't been successful for developing vaccine against hepatitis B. So this ends the viral hepatitis. So if you have any questions, then I'll be happy to answer it. Okay, thank you very much then.